in this section, we're going to focus more on the absolute requirements as outlined by the Federal Registry law that established the accountable care organizations under the Affordable Care Act, and the results of the first pioneer ACOs and some lessons that they learned. For those of you, again, that don't know me, I'm Bob Resnick from Cary Adult Medicine. I've been in this area now for the past 20 years practicing, and I've worked with the ACO concept since its inception in 2010, from the preliminaries to the final arrangements and rules that were made here in 2011, and continue to monitor and work with some groups around the country. And I know it's essential to the success of these ACOs that everybody have a good understanding of what's expected and what needs to be done. So I've tried to put together, I've got about 10 different slide sets, and I've tried to put together a combination of slide sets and make some slides that are more specific for key physicians, but basically trying to do this so that you all have the ability to gain some more information and understanding as to what's needed to be successful with the ACO. And then we'll have another webinar that I can do for quality measures, because that's important. You have to meet quality measures to get shared savings, and then how you calculate and distribute shared savings. So again, those are the 4 webinars. Let's start with, again, what defines or what created the Medicare Shared Savings Program, and that was part of the Affordable Care Act in 2010, and it was created to promote accountability for a patient population and coordinate services and items for Medicare Part A and B, and as well to encourage investment in infrastructures and redesign care processes, with the ultimate goal is higher quality and more efficient services. All of just about everything I've referenced tonight can be found in the federalregister.gov. You'll see this Part 425, which outlines the Medicare Shared Savings. So if you need any references, you can just go off to that website and you can find all of this information for the most part. The eligibility criteria for forming ACOs, well, the Affordable Care Act allows ACO professionals, those are physicians and practitioners, and group practice arrangements to join, networks of individual practices to join, and partnerships or joint venture arrangements between acute care hospitals and ACO professionals, as well as acute care hospitals that employ ACO professionals. Now, what do we have to do when we design an ACO? Well, you have to have local accountability. There definitely has to be a legal structure. There has to be a primary care focus. You have to have a sufficient size and patient population, at least 5,000 lives. The Wake Med Key Community Care has probably about 30,000. There has to be investment in delivery system and improvements, and there has to be shared savings as well as performance measures. But there are functional requirements. You have to be able to coordinate services. You have to have management and delivery functions. You have to have population management functions that include health information technology. You have to have financial management capabilities and contract management capabilities, as well as you have to identify quality measures and be able to report on their performance. As mentioned earlier, there's a performance penalty if the ACO fails to achieve certain quality measures. Patient and provider communication is a function that the ACO has to perform, and it's key to the success of the ACO. Now, there are a couple different types of ACOs, and we'll see a little bit of that later. We saw a little bit of that in the first series, but the 2 main ones, physician groups, who focus on keeping patients out of the hospital, and they try to do this by focusing on outpatient care and using patient-centered medical home to coordinate among specialists. And then there's the hospital-led ACOs, which focus better on managing the care once patients have been admitted, and they try and coordinate that care better among providers and departments. However, the best combination, or the best one, is probably a combination of both, so that we align all of these goals together, and those are probably going to be the most successful in the near future. Now, I'm going to start with this, even though I'm going to end with it too, because the 2 take-home messages for a successful ACO are you have to have patient engagement and you have to have provider engagement. So for patients, we've got to set shared goals. While we offer them alternative ways to meet them, we can offer them. Somehow they get engaged by using home monitoring equipment or support groups. We just don't give them prescriptions, tell them to come back in 6 months. And, you know, we want to focus on things that can actually make a difference, like lowering body mass index rather than just managing medications. We have to use care coordinators that can follow up with patients to find out how they're doing related to their health. Are they eating better? Are they exercising more? Are they stopping smoking? But they need to tread lightly. You don't want to push the patient too far. If If you become punitive with patients, it's a lose-lose situation. So you have to walk a fine line that motivates the patient to do better, to engage in their care of their health and improve the outcome. So it's absolutely necessary we engage patients, but it's also necessary that you have buy-in by all the providers, and that's one of the reasons I'm trying to do this, to help key providers that want to learn more about ACOs understand what we need to do. We need to have good communication. It's not a requirement to join an ACO, but it's going to be a potential solution to where healthcare is going. So we have to make sure that we're getting accurate feedback and guidance to meet these benchmarks, and we have to change our behavior, and we will be rewarded financially. But the focus is still also getting the patients engaged, because unless their incentives are aligned with ours, they have no limitations on going to specialists, self-referring, going to ER, utilizing resources. We have to educate them why it's important to do this. We also have to empower them so they assume greater responsibility for their care. But one of the key areas is we've got to also be able to target the critically ill, as they make up 75% of the costs of healthcare spending. So we have to intervene early. We've got to prevent admissions to the hospital, identify gaps, help them from ending up in the hospital. Now, back to the main purpose here of the initial part of this talk, which is the MSSP application process. All of us that joined the ACO through WAKE were part of this application process that was filled out on our behalf. It's a very detailed application. I'm going to show you excerpts from it tonight. On some of the sections, you have to provide detailed explanations. On others, you just attest to the requirements. It's critical to understand, just because we attested to the certain requirements, it does not mean we're in compliance. It just says that we are going to do that, or we have a plan to do that. Just because we are accepted as an ACO doesn't mean we are compliant, and doesn't mean we're clinically integrated. We still have to fulfill all of these requirements. CMS is going to be very aggressive at auditing more in 2015, so it's key that we follow their guidelines. CMS offers resources to answer any questions, but we have to operate under the expectations of CMS. Too many times you'll get people trying to interpret the rules rather than trying to look at how CMS interprets their execution. So they'll interpret the rules for their own satisfaction, but they ignore the fact of why CMS created those rules in the first place. So ACOs must have a formal legal structure. This structure has to be able to distribute shared savings. It has to be able to operate under state law, and hospitals can actually use their own legal entity. So on question 3 of the application, you'll see this exact language written out here, and then it tells you if you answer yes, you have to be able to do all these things, and you have to be able to fulfill all of these functions. A key concept is understanding the difference between a participant and a provider. Providers are not participants. Participants are the actual Medicare enrolled tax ID number that alone or together with one or more of the other ACO participants comprise the ACO. So basically, an ACO participant is a tax ID enrolled Medicare number, so that's a group practice, an acute care hospital, a pharmacy, a solo practice, a federally qualified health center, critical access center, rural health center, or other entities that Medicare enrolled and bill Medicare for services through Medicare tax ID. So independent practice association, IPAs, single tax ID networks that are multi-specialty can be an ACO participant. Multiple tax IPAs are not an ACO participant. Key is not an ACO participant. Each Medicare enrolled tax ID clinic under Key that satisfies the ACO requirements is an ACO participant. And this is highlighted in question 4 of the application. Is your ACO formed among multiple otherwise independent ACO participants? Note, if the ACO participant, and this is again exact verbiage from the application, by a subset of TINs that participate in an organization such as an IHD or an IPA, the ACO is formed by multiple independent tax IDs. Accordingly, these entities must answer yes to the question. So basically, what they're saying here is that under the IPA, we are, each one of us that have a tax ID clinic, an independent Medicare participant. Now, how does that differ from a Medicare supplier and provider? Well, provider-employer are people that that bill under that Medicare tax ID. So providers that bill under their clinic's tax ID are providers, are ACO providers. So a large group practice is the ACO participant, but it's the Medicare enrolled physician billing under the practice TIN that would be the ACO provider and supplier. So the example here is an ACO participant, Carry Adult Medicine, which is the tax ID, myself as a provider or supplier. An ACO participant, Raleigh Medical Group, provider or supplier would be John Rubino. So can a group practice use only a subset of providers that bill under the Medicare tax ID for the ACO? No. Everybody that's in a Medicare enrolled tax ID, every provider has to agree to be a participant in the ACO. If they don't, then the tax ID group cannot be a member of the ACO. So it's all in or none in. So the example here is that Clinic 1 has 5 Medicare enrolled providers that bill Medicare under the clinic Medicare tax enrolled ID. Clinic 1 is the participant. Each provider is an ACO supplier and provider, but all providers in Clinic 1 that are Medicare enrolled must participate and achieve quality and other ACO requirements. The clinics can't pick and choose which providers to include or exclude if they have and they bill under Medicare tax ID. It's all in or none in. And everyone that is a participant and a provider supplier must have a meaningful commitment to the mission of the ACO to ensure its likely success. And meaningful commitment is defined as either financial or sweat equity, such as seeing patients, meeting quality, meeting cost-effective goals. Now, must an ACO participant, this is an individual tax ID, be exclusive to one ACO? ACO participants that bill for primary care services, so each clinic that bills for primary care services can be exclusive to only one ACO. Hospitals can be member of multiples. Other specialists and other healthcare providers that are not primary care are allowed to participate in more than one ACO. Why does Medicare have this? Well, in order to make this whole system work, you have to have a unique patient population. So by making primary care providers only allowed in one, that way you can assign beneficiaries, you can do benchmark sampling for quality and performance. You can basically track that patient through the system. If you allowed providers to be in multiple ACOs, you couldn't track the patients because you couldn't tell where the patient was being treated and services. It would just make it all, a big jumbled mess. So you need to have primary care providers only in one ACO. Now, can you add them once you have an application that's accepted? Yes. First of all, when we're accepted, anybody that applies under the ACO application applies for a term of 3 years. But Medicare realizes there's going to be some additions and some losses for various reasons. All we have to do is make sure we notify them within 30 days, and we make sure we have to update them as they require. But we also have to recognize that anytime you add or subtract, you change the dynamics of the ACO. You cause risk score changes. You may lose, if a big enough group drops out, it may drop your ACO population below 5,000, and then you can't be an ACO. So there's all sorts of things that change when you add or subtract your ACO participants, including your benchmarks. Now, this is kind of, this should have happened, but before we applied or before your group signed up, everyone in under your ACO participant tax ID should have committed to be a part of the accountable care organization and be accountable for quality, cost, and overall care of Medicare fee-for-service beneficiaries. So you all should have signed something that said that you were going to be part of this ACO on behalf of your tax ID. That should have been done before the application was filed. Now, can a non-Medicare enrolled entity participate in an ACO? Well, shared savings was designed only to incentivize Medicare enrolled providers and suppliers to come together. Non-Medicare enrolled entities were not eligible to form a Medicare shared savings program. But in the final rule, when there was final discussions, they decided to go ahead and give some flexibility to us to allow non-Medicare enrolled entities to be part. How we decided they were part was up to us. We could include them on the governing body, but that's only at the discretion of the Medicare enrolled ACO participants. If they are included on the governing body, they do not count as part of the 75% controlled by ACO participants that is required by CMS. So non-enrolled entities that are on the governing board do not count towards our 75%. Again, this is all outlined very well in the Federal Registry and on the Medicare site. How do you get your beneficiaries assigned? Well, step one is pretty easy. If they've received the plurality of their care from primary care physician within the ACO, then they're defined as part of that ACO. Primary care physicians, as defined by CMS in the rules and regulations, is only 4 specialty designations: internal medicine, general practice, family practice, and geriatric medicine. Those are the only 4 they'll recognize. Those are the only 4 they'll assign beneficiaries. The second step is if patients haven't seen a primary care, but they have seen a specialist or another physician practitioner, like a nurse practitioner or a physician assistant that was within the ACO, they will be assigned. So some of our clinics that have specialists as part of their clinic will actually have patients assigned to them that they may lose if that patient goes back to their original primary care physician. For example, some patients may be seeing pulmonologists or gastroenterologist or something like that and not seeing their primary care physician within the past year. So they could be assigned to our ACO, but they go back to their primary care physician. They will be reassigned. What are primary care services? 99201 through 99215, the nursing facility codes 304 to 340, and the home visits 341 to 350, as well as the Welcome to Medicare visit 402, GO 402, and the GO 438 and 39 wellness visits. Again, CMS recognizes only 4 classes of primary care providers because this is for Medicare beneficiaries only. This program was designed specifically for that. So it's internal medicine, family practice, geriatrics, and general practice. Well, the question comes out, where do pediatricians fit in this? Well, they were not included in the Medicare Shared Savings Program as created by the Affordable Care Act because they don't see enough patients to satisfy quality and cost-effective treatment. But the Congress did recognize that pediatrics plays a big role in this, and they, in Section 2706, they set up the patient protection, under the Patient Protection Affordable Act, they authorized the states to establish a medical ACO for pediatric providers that would be under the Medicaid incentive payment system. So states can set this up for pediatricians. Now, as far as commercial ACOs go, pediatricians can play a role and will play a role. Beneficiary attribution, well, this is based on the provider's TIN again. As we said, just to summarize, the program is only applicable to Medicare fee-for-service, not Medicare Advantage patients. ACOs will be granted beneficiary attribution based on the historical utilization of these beneficiaries, but the attribution is mainly to primary care physicians unless specialists are the only ones that have seen the patient. The key is you have to have at least 5,000 attributed lives to be eligible for MSSP. Can a patient see whatever doctor they want if they're part of the ACO? Absolutely. If a doctor participates in an ACO, a patient in that ACO can see any health care provider who accepts Medicare both in or outside of the ACO. Nobody, not an ACO doctor, not an ACO hospital, can tell a patient who they have to see. So we have to realize patient satisfaction and, again, patient engagement, which I'm going to keep emphasizing, are key. We need to make sure these patients understand how the ACOs will impact their care. We have to get them engaged in their care, and they have to have some understanding of health care cost and the importance of efficiency care delivery. Their health care outcomes are going to depend on how much they participate in their care. But again, they're also, at the end, going to fill out satisfaction surveys that will become part of our quality metrics that we must be successful on. So, just to summarize those referral requirements, patients cannot be forced to see specific providers. They are free to see any Medicare enrolled provider they wish. They are free to go to any Medicare enrolled hospital. Cost savings in the MSP are generated through utilization, not control of patients' referrals to specific entities or specialists. So we decrease costs by decreasing the amount of referrals we need when appropriate, or decreasing the utilization of unnecessary resources like ERs versus using our urgent care or our own office. And this has come up in the multiple conference calls recently because a lot of physicians have been using programs like the Infinite program that we are using. However, there's some debate as to whether this can be used for Medicare, and my assessment is that it should not be used for Medicare because you have to have access to all the providers and all the entities that are Medicare enrolled providers. And if the system doesn't have that, then you're limiting who you can refer to. As well, there shouldn't be a charge to refer a Medicare patient to that facility. So there's some questions on how all this works, but the main thing is we have to have open access to all Medicare enrolled providers and entities, and most of the computer systems limit that access. So we've talked about this briefly in the first part. We'll have a whole webinar dedicated to it, but remember, we have to have satisfactory performance on 33 quality indicators. The reason I'm bringing this up right now is because people think that just by getting these quality metrics that they're actually improving care, and if you look at most of them, they're really not probably improving care. So these things are really simply signposts along the way. They give directions to health, but if we want to be successful, we have got to take it a step further. We have got to look and figure out what quality improvements we need to make that will impact the patient's health and cost savings. So these single metrics like what is blood pressure taken, that doesn't improve care. But when we look at fulfilling a cluster or galaxy of clusters in the care of a patient, that will improve the outcomes and result in quality of care. So the only way to prove the quality is helping is through auditing and outcomes. And we have to mine that data and look at that data to make sure that what we are doing is making a difference. And here's an example of a cluster. Rather than just measuring one of these for a diabetic, we wanted to make sure that we keep all 8 or 9 of these quality metrics done with each diabetic visit that we see. It just doesn't do us any good just to meet the 2 or 3 that Medicare may be requiring on a basis. We need to make sure that we look at the entire patient and we look at the entire spectrum of care for that patient, and we meet all the quality indicators that will help improve their outcomes. And again, this is just showing some of those examples. And they want hemoglobin A1C below 8. We know probably it's all better than 7. Same thing, the LDL being a little bit lower in diabetic patients. All these things, again, they're set up to be met as part of the quality, but in reality, we need to take them to a different level if we're going to improve outcomes. And same thing with coronary artery disease. So the ultimate goal here is shared savings. As participants, we will be rewarded for achieving quality and cost benchmarks. But how is that benchmark calculated? Well, if you paid attention to the risk coding and things that we've talked about over the past couple weeks, that is where they come up with kind of the per capita Medicare cost of the beneficiaries based on the risk scores of our patients. Now, they do use 3 years. 3 years in setting these benchmarks. So for 2014, they'll use 2011, 12, and 13. But the ACO benchmark is not set for an individual ACO participant. It is set for the ACO as a whole. So this is based on the per capita Part A and Part B for all beneficiaries who are assigned to the ACO in any of the 3 most recent years prior to the start of the agreement period. So basically, they're going to set these benchmarks for all the patients assigned to us based on their previous 3 years of utilization and expenditures. Now, the benchmark is trended. It uses national Medicare expenditure growth factors. It's risk adjusted to reflect the most recent benchmark mirror. And it's also weighted the most in establishing the three. This is weighted, like I say, the most in establishing the 3-year historical benchmark. So the benchmark is always updated annually. It's Part A and Part B. They do calculations for absolute growth and national expenditures, and they make adjustments. So CMS develops these performance benchmarks for ACO and assess whether they qualify for shared savings. ACOs receive shared savings if their expenditures for their assigned beneficiaries are below the benchmark. As we showed in that graph in the beginning, the difference between that benchmark and the actual expenditures is the pot that we split. Now, there are one-sided and two-sided payment models. We're in the one-sided, which most people are in, which is just the Medicare shared savings. There's no risk required until after year 3, but this is a 3-year agreement, and I think you're going to find in 3 years they're going to probably do away with that unless they figure out how to engage the patients better. So the one-sided risk payment model is the only one we're concerned with, and that's the one we're in. At some time, there may be transition to that second one. And, of course, we're going to develop the formula for distributing the shared savings. And this is what's required on the application. As you see, it's very detailed, and this information had to already be provided when we send in the application. Now, distribution of shared savings, biggest source of conflict more than any other issues with ACO. This is why it's imperative that you have a governing body that represents all the participants, large and small. Because you're going to have to define things. If the provider doesn't meet quality, then the provider should not share in the square savings. Yes or no? The percent distributed based on quality versus cost of care. The distribution to the ACO participants. Should you distribute to the participants rather than individual providers? We almost have to, because there's no way under the Medicare system that you're going to be able to identify anything but that tax ID. You're going to have to allow each clinic to figure that out for themselves. So you're going to have to distribute to the participant and not the individual provider. And then retain savings for reinvestment. You're going to have to do some sort of growth calculation. Data and analysis, very big source of frustration. A lot of providers are just unwilling or just unable to face current reality. They see audits and their performance, that can't be right, rather than trying to look at those numbers, look at the numbers that they're actually in their system, and see if there is a basis for that performance. So analytics, when we track data, audit performance, we have to make sure that the data that we're providing is truthful and reliable. If it is not reliable, all it's going to do is create problems, and garbage in, garbage out. We start giving garbage out, patient or providers lose confidence, and therefore the whole process fails. So it's imperative from the beginning that we validate all information that we give, and that information is truthful, because the only way we're going to impact performance is to make sure that we're giving reliable data to providers. They have to believe it. Well, as I said, one of the major challenges is in shared governments, because you have to coordinate all these issues across all these different patient populations between all these different organizations and different tax IDs. They have to provide guidance to efficiently manage patient care across this whole continuum of healthcare services. So there's a lot of challenges here. That's why, as far as I'm concerned, I think this is the most important part of getting that ACO structurally sound. As again, I said, patient engagement and provider engagement is critical, but if you don't have your governance set up right, you're going to fail. And this is the actual question on the application. Does the government have oversight and strategic direction? Is it a transparent governing process? Fiduciary duty. This is very key. The members of the governing body have to have explicit responsibility to the ACO when making decisions. They can't make decisions based on their own clinics, their own networks, or whatever. It has to be for the ACO, and there's a conflict of interest policy that we'll see in a couple minutes that every one of them has to sign too, but it has to be separate and unique. This is an example of one ACO, but again, you can make these any way you want, and you'll see in a minute that basically you get free reign to do whatever you need. So, 425.106, Federal Registry, the shared governance as created by the Affordable Care Act. Three main components. ACO must provide for meaningful participation in composition and control of the ACO governing body for ACO participants. Those are the tax IDs or their designated representatives. Basically, this is the tough one, because you have to have a mechanism that allows big, small clinics, all of them, to be represented. Initially, Medicare did not think that there were going to be more than 4 or 5 different tax IDs in these ACOs until all these physician groups started doing their ACOs, and you start having 20, 30 tax IDs. It's very inefficient to make 20 or 30 people be on the board, but that was in the original intent, the original rules. It was every participant had to be on the board. They changed that, and they gave flexibility to the groups to come back and say, okay, you figure out a mechanism that best represents all your tax IDs, and that's sufficient. The second requirement, you have to have a Medicare beneficiary that's served by the ACO, and that person can't have a conflict of interest with the ACO, so you're not going to use excuse me, a physician that's in your group that just turned 65. That's not what they're looking for. And you're not going to use your mother and father. They don't want a family member. Basically, this was a key concern of Medicare, and they actually wanted 2 or 3 of these people on the board, because they want to make sure that you have typical Medicare patients in your population on your board that are sticking up for the rights of the Medicare patients. In the way ours is initially laid out, we have this person voting, and I think I can be honest, that's an absolute ridiculous thing, because we have a hard enough time getting representation, and we shouldn't allow the Medicare beneficiary to be a voting aspect of our board. We somehow need to balance that with Wake Med, but I think I have not seen many of these ACOs where the Medicare beneficiary is actually a voting member. Again, they're there to provide guidance and to stick up for the Medicare patients, but usually not a voting representative. And the third one, and the most important, 75% of the control of the governing body must be held by ACO participants. That is critical. So the ACO application, actually all 3 of those are on there, and you have to answer them or attest to them. So what are these guidelines? Well, basically, provide that you meet the requirements of the 425.106, you have the flexibility to set up your governing body any way you want. You can have one person or 50 people. It doesn't matter. There are no requirements for specific board positions or the number of committee members. That's all up to you. So in our case, if you have 30-plus tax ID participants, how do you make sure that all 30 have a meaningful contribution in control and composition of the governing board? Well, like I say, in the original proposal, they wanted everybody to have representation, but in the final rule, they decided give the ACO some flexibility as long as there is a mechanism to satisfy the meaningful contribution requirement. So basically, each ACO participant has to have some meaningful contribution to how the governing board is chosen. And you can't just do a vote by physicians. There's way too many variables there, and your smaller practices aren't representative. You have some providers, even the small practices, see 3 times as many Medicare patients as others. They get 3 votes. Some physicians are not meeting some of the inclusion and exclusion criteria. You know, they're not ACO participants as per the ACO requirements. So as far as like meaningful contributions and things like that, which I'll show in a minute, many groups set up minimum requirements that are required for their governing body. Some providers don't satisfy the quality measures. So how do they get to vote for somebody that does? I mean, there's so many different variables here. And the reality is that ACO participants are all in or all out, meaning that a practice with 25 providers is excluded if one or more of the providers are not participating. So 20 providers practice versus a 1 provider practice, if one of them's not for, is out of it, the whole group is out of it. So it's very difficult to just do it by a vote by physician. So there's been a lot of innovative solutions. A lot of groups have broken the participants into subgroups. The smaller groups, the 1 to 2 provider groups, and the other ones with the 3 to 5 MD, and then those with more than 5, and have each of these groups elect a governing member depending on the number you have on your board. Then you get some representation. Then some just allow each tax ID participant to have 1 vote because it's all in or none in. But again, that's almost back to letting every physician vote, because then you disadvantage the bigger practices versus smaller practices. And some of them try and allocate votes based on the number of patients, but again, you get into discrepancies bigger and smaller practice. The best solution is for the group to decide, but it usually requires some blending of the above with some at-large elections. But there is no requirement for elections. That's a key concept. Most people don't understand that. The requirement is for a mechanism to allow the ACO participants to have some contribution to the composition of the governing body. So they have to have some meaningful contribution, but that doesn't mean you have to have a vote. You can all decide this is the way it is and this is who's going to do it. But you must account for small and large groups. And your governing board members should meet the ACO inclusion and exclusion criteria. Now, again, here's some examples that some of the groups I've worked with have used. You know, you have to see at least X number of Medicare patients. You don't want somebody just doing research or administrative and not being involved in practice sometimes to be someone that's making these decisions. A lot of groups make you take Medicare assignment. I will tell you right now, the groups that aren't taking Medicare assignment, we have data that shows that because of the patients having to pay that extra 10%, the utilization of specialists and outside care is tremendously higher because they're on fixed incomes. They realize if they go see their primary care provider, they're going to have to pay that extra 10%, whereas if they go see the cardiologist or the endocrinologist or whoever, they accept Medicare assignment and they don't have to pay anything extra. So a lot of groups decide that everybody's got to take Medicare assignment. Some groups say you have to attend X number of meetings, you have to provide data. There's all different requirements. A lot of this is outlined in your initial agreement, but it should be updated from time to time. Then you have exclusions, of course, if you don't meet quality criteria. What do you do if you don't adhere to ACO guidelines by CMS? So again, that's all for the group to decide. As I said, there has to be a conflict of interest. For everyone that's in the governing body, they ought to sign this and understand this because this is key, and Medicare will audit this. Now, can a non-board member serve on a committee? Like, for example, a chairperson of the Finance Committee is not an ACO governing board member? Yes. In fact, like I say, again, this is on the CMS website. There's no stipulation. In fact, it's encouraged. In a group like this, it would be really encouraged to get more members from key involved in committees. The more members that get involved, the better we get cohesive and the better we get buy-in to this whole concept. So it does not, and it should not be limited to just governing body people on these committees. These committees should be open to all ACO participants and providers. Now, a compliance officer is extremely important. It's not legal counsel, and it reports directly to the ACO's governing body. You have to have a way to address compliance issues. You have to way to report it, and this is a very important position. There is another position for quality control person, but this question comes up all the time. Can they both be the same? It's very difficult to find the same person that can do quality control and compliance. They are different aspects, so usually they are different people. Now, in the ACOs I've worked with, these are some examples of the committees, because you are going to find that it is very difficult to manage all aspects of the ACO from just a few people. You have to have a lot of different people working on different aspects to keep this going. And again, you need to keep focused, and you need to have someone championing the whole process. You're going to have some executive leadership, which manage the venture's overall direction. They define the guiding principles, align the partners, deliver the defined clinical and financial goals. The operational leadership, they make and implement changes day to day. They look at the clinical, financial, and support functions, including population management, network management, and technology. They don't make changes, though, to provider clinical practice. So, the governance, you've got to choose a process that allows for representation of the participants. That's part of the guidelines. The source of most conflict, like I say, is a governing body that does not account for all participants, but communication is critical for guidance to achieve the goals. If you have a governing body that's not communicating, you're not going to be very successful. So let's take a quick look at some of the results from the Pioneer ICOs, the quality, cost effectiveness, and some of the lessons they learned. Now, all Pioneer ACOs were awarded for reporting quality measures. Realize they reported them. They were not measured. This was not tied into their performance. It was tied into performance for 2013. The Pioneer ACOs did better at blood pressure and cholesterol control for beneficiaries with diabetes than did the managed care plans. They did better on their readmissions relative to the fee-for-service benchmark. And they got higher ratings on their satisfaction surveys than did the fee-for-service. So overall, quality seemed to improve. As far as financial, their spending grew about 0.3% for their 669,000 beneficiaries. The same population averages about 0.8, so there was a 0.5% savings there. These organizations collectively beat their spending targets by $87.6 million, 33 of which went to the Medicare Trust Fund. And then these savings came largely, though, from just 13 organizations through reductions in hospital admissions and readmissions. The 19 other pioneers, 17 had spending that did not significantly differ from their targets, and 2 actually had losses. So 18 of the pioneers delivered savings, but only 13 of them had enough savings, and that was greater than the 1% of the CMS benchmark to make them eligible for shared savings. 14 did not deliver savings, and 1 actually sustained losses, requiring them to pay some money back. The big thing is most all the pioneers now have transferred from the risk to more of the MSSP model, where there's less risk. 8 of the 14 pioneer ACOs that did not achieve savings are transitioning out of the Pioneer ACO program. That includes 6 organizations that are going into the MSSP and 2 that are exiting altogether. The University of Michigan, they didn't make its savings, but they've decided the MSSP is a much simpler infrastructure to sustain the financial risk, or to sustain the goals and not to bear the financial risk, so they're going to transfer into the MSSP program. Geographical differences, 14 or 78% of the ACOs that achieved savings were in the Northeast and Midwest. 9 of the 14 that had losses were in the West and Southeast. So the question is, did those ACOs with lower benchmarks have less of an opportunity? Well, actually, that didn't pan out, as it looks like the ones that actually didn't achieve savings actually got more per beneficiary, $259 more. So that theory doesn't hold. You know, there's the possibility is that these providers in the lower cost market just established the necessary infrastructure to deliver the care efficiently. They were better organized, and they had better processes in place. Interesting on the EMR results, there's not a predominant disk system being utilized. Epic was used by 31% of those that had savings, NextGen 19%, and then Allscripts, Athena, G-Centricity, all used in one organization. But of the 12 ACOs with losses, 5 were using Epic, 5 were using Allscripts. And the types of ACOs, this was kind of different. There was the 18 that had savings, 10 of them were IDNs. 3 of them were hospital physician groups. 5 of them were just plain physician groups. But the 14 that were without savings, half of them were physician groups, where the other half were IDNs and hospital physician groups. So what lessons have we learned? Well, one, everybody hears the word ACO as a buzz phrase and tends to rush into this, fills out applications, and thinks they're going to be successful, and that's just not it. There are big investments in time and resources and intellectual capital, and if you don't realize that, there's a tremendous amount of work. You're not going to be successful. So sometimes you have to take a breath of air after you fill out this application, sit down, make sure you have all your ducks in a row, and make sure you have all your processes in place, because if you think it's going to be easy, it's not. It's going to take a lot of time and effort. Someone in the organization has to be the owner and chief this project through and make sure someone's keeping track, because it's very easy to get off track in certain areas, and someone has to be kind of championing the process. The hospitals and health systems, it's much easier if they break this down in teams. It's a big challenge to do this communication and work on a large scale. It's much the more successful ones, they broke them down into teams, and this made the challenge more manageable. You have to have a plan, but you also have to have a plan that's dynamic and changed. You have to reassess this plan, measure this plan, and make sure the plan is working, and if not, you have to be able to realize that before you're too far down the wrong path and make the changes. So just putting a plan down is not do or die. If it doesn't work out, you've got to have the flexibility to change it, and you've got to change it quickly. You don't wait and try and prove your point by going too far down. You just have to realize when you've made a mistake, and you have to change it. And you also have to educate your employees and other people, your Medicare beneficiaries, your physicians. Everybody has to understand what the ACO is and how it has to work, and that's one of the reasons trying to do this presentation, to help you better understand what needs to be done. You have to alert the beneficiaries, through informative mailings. You have to encourage them to ask questions to the care coordinators, to to helplines, or even physicians when they follow up. But the other biggest thing is you need to get to know the family and prepare for it to grow. Data is critical. We have to mine the data for patterns that will help us communicate appropriate services and engage patients. To do that, we have to know our patients on a deeper level to manage and coordinate care. We need to find innovative solutions to care management. This is just one example. I think it's a little far-fetched, but it was one that was presented at a conference where they could not get this lady her insulin. They found out she was spending all the money to get her roof fixed. So one of the care coordinators actually got her qualified for a grant to get her roof fixed, and then she bought her insulin, and she ended up in the hospital 50% less for that year. So I started with this. I'm going to end with this. The key to success of the ACO is we have to also change the patient's behavior. We have to educate our patients not to self-refer. We have to educate our patients what to expect at a referral. We can give them a list of preferred specialists, but they have the freedom to go anywhere. We have to give the patients resources for additional information. All of us as physicians are responsible for educating the patients so they can make informed decisions about their health. We have to show them how to do this. We have to give them ways to do this, and we have to provide them resources to do this. We can utilize technology, but Medicare patients, you have to kind of gauge. Some of the older ones are not going to be very technological savvy, but there's a lot of them that are. So you have to harness their smartphones, their computing power, and you have to use these things to your advantage. Use apps on fitness, weight control, diabetes, or videos and audios on the internet. Through technology, patients do remain engaged, invested in their own well-being, and those that are engaged in their care have better outcomes. So if we get them more educated about their condition, compliant with treatment and prevention recommendations, and more involved in day-to-day monitoring, we will have success. We have to make sure that our chronic patients with conditions can access their labs get to the specialist, they can make appointments and email physicians. They have to have access. And we have to make it easy for people to track and share their data in between visits. So, last time you're going to hear it, but we have to engage these patients in their own care, and we have to work together to achieve more transparency, coordination of care, and accountability. We need to engage not only the patients, but we need to engage their families and their caregivers. Care managers are going to play a key role in this, notifying PCP when the patient is admitted, discharge, working on discharge planning, working on post-acute care appointments secured at time of admission. The goal, is to see this patient within several days of discharge, at least no more than 1 week. But they have to follow these patients indefinitely. Patients want to be educated about their health and want to learn more about the most efficient, more efficient ways to access quality of care. We need to teach them how to make their lives better. So, care managers now focus mainly on the chronically ill, but in the future, we've got to change that. We need to evolve this into care management which focuses on wellness prevention. We need to get them to follow all patients. We need them to get more involved to make more efficient care for entire populations of patients, both inside and outside the hospitals. So the case managers tomorrow will have to consider the clinical, financial, and patient advocacy functions simultaneously as they balancing these competing interests. Now, in closing, just a couple lessons from a couple of the recent ACOs, Steve Knuckles, Coastal Carolina ACO. Their organization hired 11 care managers but did not hire the extra staff to work at its call center. So they had this 24/7 nurse triage line that was supposed to assess patients' complaints and determine the appropriate course of action. However, they hired an outside company that really didn't know much about their community. So what they do, they referred them all to the emergency department. Donald Stump, American Health Network, he brought up a good point that sometimes you have to identify the 10% of your sickest patients and tell them it's okay to call their doctor or case manager on night at weekends. If you can prevent that use of the ER or that unnecessary trip to a specialist or to another cost center, then you're going to ultimately help the cost savings of the entire effort. So, we typically instruct these people to go call 911 or go to the ER, but you have to let these people know that it's okay to call your case managers or your providers. So, recipes for success. Okay, we've got to be a collaborative, physician-led, physician-driven organization. It's going to take time. We've got to establish guidelines. We've got to measure and enforce parameters to improve care, improve value. We need to establish a strong infrastructure and ITs for the hospitals and our physicians. But we need to establish one incentive system the physicians and hospitals control, understand, so they can get results. We must maintain a relentless focus on redesigning clinical care delivery across the continuum to find new ways of improving efficiency, service, and quality. Where do we see the future of ACOs? Well, again, we've got to get physicians engaged or we're not going to have a future. They will be rewarded for changing providers or for changing behavior. There must be a more sustainable payment model to survive long term. We're going to reach a marginal cost savings where we're not going to be able to eke out much more cost savings. So we've got to come up with a more mature, predictable payment stream to align incentives for payers and providers that focuses on this. And then there's going to be competitions between ACOs. This will result in the bend in the cost curve and improved quality of care too. So if we can meet the performance measures, improve quality, save money, this will be the model for the future. But it has to be attractive to encourage participation. So this is why all of us that are providers need to understand the need for this and how it can be beneficial to both our patients and to ourselves long term. We have to transition away from the fee-for-service system and transition more to value-based contracting. We're a long way from risk models, and there will be a much longer period of transition than I think anybody realizes. We are going to have to get the patients more engaged if there's going to be a risk transition. But Medicare is also going to have to make some changes to engage the beneficiaries and ACOs. They may have to start sharing savings with patients, reduce cost sharing, or reduce premium for those beneficiaries that utilize providers within the network. So there's a lot of things that Medicare can do to help change this too. So this ends the ACO webinar. Like I say, there are 2 other webinars, quality measures and calculation and distribution of shared savings. Those should be out there somewhere during the week of December 10th or so. If you have any questions or feedback, again, please give me a call. I'll carry adult medicine, 919-859-2566. Or if you have any other questions or feedback, you can email me at info@keymh.com. Thank you for attending tonight, and if you have any questions again or feedback, please let me know. Thanks.